Welcome back to the deep dive. We're here to cut through the jargon, pull out those essential insights, those, aha moments, and hopefully leave you just curious enough to keep exploring. Today, we're plunging into some pretty intricate medical territory. We're going to unpack craniofacial dysostosis syndrome, CFD for short, our mission, take some really dense medical research, pull out the crucial bits, and give you a clear picture of these conditions, their impact, and the, frankly, incredible surgical journeys involved. Think of it as your shortcut to being genuinely well-informed on a tough but really important area of medicine. Okay, so to really get a handle on these syndromes, we first need to appreciate the ingenious design of a newborn's skull. You know, those soft spots, the flexible areas. Cranial sutures, they're built for two really critical jobs. First, they let the baby's head flex just enough for birth. But second, and this is just wild, they let the brain grow incredibly fast, like tripling in volume in year one, quadrupling by age two.
Yeah, it's phenomenal. A real marvel of engineering, like you said. Making sure there's always room for that rapidly expanding brain. And what's fascinating there is just how finely tuned that whole process is. Craniosynostosis, that's when one of those cranial vault sutures fuses up too early. Often happens in utero. And the key insight, explained by Virchow's law, it's not just passive. Growth gets actively restricted perpendicular to that fused suture. And the skull then tries to compensate, overgrowing in other directions. That's what causes those distinct, sometimes dramatic, skull shapes.
Ah, okay. So it's an active but sort of misdirected compensation.
Exactly. And it's amazing. Normally, just a tiny bit of pressure, like 5 millimeters of mercury from the brain, is enough to stimulate perfect bone growth at the suture margins.
By the right.
When that little dynamic gets disrupted, the whole system goes awry.
Right. So it's not just the fusion, but the skull's attempt to cope that shapes things. That's foundational. And that distinction you mentioned between general craniosynostosis and CFD, that's really key here, isn't it?
Absolutely.
Because most craniosynostosis might just be the skull vault, but CFD, these are syndromal. The problem goes deeper. Skull base, mid-face structures.
Precisely.
We're talking Apert, Cruzon, Pfeiffer, Sayther-Chotson, Carpenter syndromes, even that severe cloverleaf skull.
That's right. And connecting this to the bigger picture, many CFDs have a genetic basis, particularly mutations in the FGFR genes, fibroblast growth factor receptor genes, usually autosomal dominant inheritance. So a 50% chance for an affected parent to pass it on.
50%? Wow.
Which then leads to the critical question, how do you even diagnose these? Some need molecular testing for the specific gene change. Others rely on clinical findings. And those findings can overlap sometimes, making it a real diagnostic puzzle.
Okay, let's shift gears a bit. From the genetics and the anatomy to the real-world impact. This is where it gets really sobering and incredibly challenging for patients and their families. The functional consequences.
Indeed. The ripple effect is profound. Let's start with brain growth and intracranial pressure, ICP. That premature fusion limits the brain's normal growth, forcing abnormal skull expansion. Untreated, this can lead to, well, decreased cognitive and behavioral function. But elevated ICP is the most serious immediate threat. It's tricky to spot in infants. Signs are subtle, slow onset, but left untreated. It can cause papilledema, the swelling of the optic nerve.
The connection from eye to brain.
Exactly. And eventually, tragically, blindness. Then there's vision itself. Many CFD syndromes cause shallow orbits. Eye sockets aren't deep enough.
Right, so the eyes bulge out more.
Precisely. Exorbitism, exophthalmos, and that puts the cornea at risk. Exposure, abrasions, ulcers, trauma. In severe cases, the eyeball can even herniate. An emergency.
Hello.
We also see orbital hypertelorism, eyes too far apart, strabismus, misaligned eyes, and sometimes saposis, a droopy upper eyelid, and hydrocephalus, excess fluid on the brain. That occurs in up to 10% of CFD patients, often because the cranial base is narrowed, pinching off the normal flow of cerebrospinal fluid, CSF.
And diagnosing that must be tough, too, with the skull already misshapen.
Very tricky. Interpreting CT scans requires a lot of careful judgment, serial imaging.
Okay, brain, eyes. But I can only imagine the fear for parents when it affects breathing and feeding, especially for a tiny baby. That must be critical, right, from day one?
It absolutely is. Newborns are obligate nasal breathers. They have to breathe through their noses primarily. But mid-face hypoplasia, common in CFD, shrinks that nasal and throat space.
So they're forced to breathe through their mouths.
Right, which makes feeding incredibly difficult. They can't suck and breathe properly at the same time. This often leads to failure to thrive, sometimes needing feeding tubes. And it directly links to a very high rate of obstructive sleep apnea, OSA. Up to 50% in kids with Aperts, Cruzons, or Pfeiffers in the first 6 years.
50%? That's huge.
It is. And untreated OSA, severe consequences. Cognitive issues, developmental delay, serious heart and lung problems, even sudden death.
How do they diagnose that definitively?
A formal sleep study. Polysomnography. It measures breathing pauses, oxygen drops during sleep. That's the gold standard. Treatment options. Well, they range from tracheostomy and airway in the neck.
Drastic, but sometimes necessary.
Right, or removing tonsils and adenoids, using CPAP machines. But often, midface advancement surgery is seen as the most direct fix, moving the midface forward.
Does that always solve it?
Not always. Studies show even after major surgery, a significant number might still need CPAP or have residual issues. It might be inadequate advancement or relapse, or even underlying issues like poor muscle function in the throat, maybe linked to the FGFR mutation itself. It's complex.
It's clear the impact goes way beyond just the skull shape. You also mentioned dental anomalies.
Yes, quite common. A Pert syndrome, for instance, often has a high constricted palate, maybe a 30% rate of cleft palate, severe crowding of teeth, a prominent lower jaw, what dentists call an angle class 3 malocclusion. Hearing deficits are more common too. Conductive loss in croissants, frequent ear infections, otitis media, and atropurts. And just briefly, some physical differences help to distinguish the syndromes. Extremity anomalies. Like in Appert's, you see severe syndactylly fused fingers and toes. Often joint fusions too, elbows, shoulders.
Okay.
And Pfeiffer's syndrome often presents with characteristically broad thumbs and big toes. These are all pieces of the puzzle for diagnosis and planning.
It really is incredible thinking about how far the surgery has come from, well, pretty crude early attempts to today's techniques. Let's walk through that evolution. A century of innovation, really.
Yeah, the very first attempts back in the late 1800s, Lanalong, Lane, they tried strip craniectomies, just cutting out the fused suture.
Simple idea, but I imagine complex problems.
Exactly. Problems like the bone just growing back wrong,
Yeah.
or the skull molding unpredictably. Even famous surgeons like Cushing were skeptical early on. It took a while to figure out better approaches. Modern craniofacial surgery really started taking shape maybe in the 70s. The shift was towards doing both things at once, releasing the suture and reshaping the vault in infants. But the real game changer was Paul Tessier in 1967. His presentations basically launched the field as we know it.
What did he introduce?
So many innovations. New places to cut the bone, new osteotomies, a combined approach, working inside and outside the skull together, using the patient's own bone for grafts, autogenous bone grafts, big deal. External fixation to hold the new shape.
Wow.
And that led to techniques like the monoblock moving the forehead, orbits, midface, all as one unit, and Tessier's own facial bipartition for a true 3D correction, especially key for Appert's.
And the tools got better too, I assume.
Oh, definitely. Metal plates and screws came in around 68. Now, for infants, especially in areas that don't bear a lot of load, we often prefer resorbable materials. They dissolve over time.
Okay, so lots of surgical advancements. What about newer things, like distraction osteogenesis? That sounds complex. Stretching bone.
It is. Distraction osteogenesis, DO. It's a way to gradually advance bone, especially when there's severe hypoplasia, meaning underdevelopment. You place these devices, surgically anchored, and they slowly pull bone segments apart, usually about 1 millimeter a day for several weeks.
A millimeter a day, slow and steady.
Right. But it's generally seen as adjunctive, meaning it helps other surgeries. It's not usually the primary fix by itself. It's also pretty labor-intensive. And controlling the final shape, especially vertically and sideways, can be tricky.
Any downsides, complications?
There can be. Infection is one concern highlighted in studies. Some early studies even reported significant complications in DO groups. And critically, research by prominent surgeons like Posnick and Wolf, and later Bradley, found that even when you achieve more advancement with DO, there wasn't necessarily a clear correlation with better functional outcomes like breathing or better aesthetics.
Interesting. So bigger isn't always better.
Exactly. It connects to the bigger picture. Choosing the right technique involves carefully weighing immediate results, long-term stability, and the patient's overall well-being. Sometimes a more traditional approach is just as effective or even preferable.
And the timing of all this, these are massive surgeries. Is there a best age, or does it vary?
It's all about staging reconstruction, timing procedures based on facial growth, protecting the brain and eyes, and considering psychosocial development. It's important to note that idea that early surgery might unlock facial growth that hasn't actually been proven scientifically.
Right.
So surgeons constantly balance the need for early intervention for function against impacting future growth and knowing more surgeries might be needed later. It's a long-term plan.
Okay, let's bring it together now. Dive into those specific syndromes you mentioned earlier. How do these principles apply? Tailored strategies.
Absolutely. Yeah. Let's start with Curzon syndrome. It's relatively common, autosomal dominant, generally less severe than Eppert-Snow hand-foot anomalies. Typically, you see bicoronal synostosis, fusion of the sutures across the top of the head, front to back, leads to a short, wide skull, brachycephaly. Also, mid-face hypoplasia, proptosis, bulging eyes, that angle class 3 bite. Mostly SGFR2 mutations.
So what's the surgical plan usually look like?
Typically, the first big step is cranioorbital decompression and reshaping, around 9 to 11 months old. Sooner if ICP is high. Goal is more room in the skull, more room for the eyes, better forehead shape, often aiming for a little overcorrection of the brow ridge in infancy.
And later?
Repeat craniotomy if ICP becomes an issue again. For the midface, later on, managing that total midface deformity often involve complex osteotomies like the monoblock or Lafort III to bring it forward. Though Lafort alone can sometimes create aesthetic issues, facial bipartition is rarely needed in Curzons. Then, definitive bite correction, jaw surgery, maybe chin work that's usually held until skeletal maturity, teenage years.
And CT studies confirm this staged need.
Yes. They show early surgery helps brain volume, but the orbit and cheekbone measurements often don't normalize until later mid-face procedures. Monoblock procedures do show improvements towards normal ranges for things like eye spacing and protrusion. Okay, now Apert syndrome, caused by specific FGFR2 mutations, characterized by that severe, complex syndactylly fused fingers and toes. Often joint fusions too, elbows, shoulders. Fused neck vertebrae are common. Distinctive look around the eyes to S-shaped eyelid droop, downward slant at the outer corners. Hydrocephalus is actually less common than in Curzons.
Surgical plans similar initially?
Initial cranioorbital decompression and reshaping in infancy, yes. However, for the midface correction later, facial bipartition is often preferred.
Why that specific technique?
Because it allows for a more complete 3D correction. Opert's often presents as flat, wide, and retrusive. Bipartition lets you move the orbits and cheekbones inward, medially, while widening the upper jaw. A standard Lafort throw just isn't enough usually. And again, final jaw surgery at skeletal maturity.
What do the CTs show for Epert's?
They really highlight the need for staging. They confirmed significant deformities before surgery, wide vault, hypertelorism, proptosis, and crucially, showed that the early reshaping often didn't hold its corrected shape long-term in Epert's. Measurements were still far from normal a year later, reinforces why ongoing reconstruction is necessary. Interestingly, intracranial volumes in Epert's often exceeded normal even after surgery unless hydrocephalus was present. And studies show facial bipartition generally has low morbidity for these patients. And just briefly, the other syndromes, Pfeiffer's, Carpenter's, Saythrop-Chotson, they each have unique features. Broad thumbstos in Pfeiffer's, short stature heart issues in Carpenter's, subtle webbing in Saythrop-Chotson. But the craniofacial reconstruction often follows similar plans to Curzons, and the cloverleaf skull anomaly, which is a severe presentation seen across different syndromes, always requires aggressive early multi-stage surgery focused on decompressing the brain.
The sheer complexity is just staggering,
Yeah.
but matched by the dedication to improving life for these kids.
Absolutely. And, knowledge is great, but it's most valuable when understood and applied correctly, which is why the multidisciplinary team is so critical here. Craniofacial surgeons, pediatric neurosurgeons, maxillofacial surgeons, orthodontists, all working together, often following a child for many, many years.
That collaboration, that long-term view, it's clearly essential. This whole deep dive really underscores that philosophy of staged reconstruction, timing it with growth, functions, psychosocial needs. It's a continuous effort to improve quality of life. And, when we look at the incredible progress made so far in treating these syndromes, it really makes you wonder what's next. What new biological insights or tech breakthroughs might totally redefine reconstructive surgery? Could we see more personalized approaches? Less invasive, maybe even preventative, intervening at the genetic level somehow? How much further can we push things, restoring function, aesthetics, fundamentally changing the course for these kids in the future?